All right, thank you very much for the invitation. I'm going to talk about something called isocapnic hyperpnea. You may be more familiar with the word hyperventilation for physiological reasons, for just the way we name things. The hyperventilation means there's a drop in CO2. The hyperpnea means that you can breathe very hard and not change your CO2. So we'll just call that IH. So when you hear me referring to IH, it's basically the hyperventilation. And I'm going to go through and explain the relationship between IH and carbon monoxide elimination. So basically, we're addressing carbon monoxide poisoning. It's one of the most common causes of poisoning in the world. It's a silent killer, and it kills by asphyxiation. So the way it works, so in this slide, the green, by the way, I don't know if you can see my pointer. Maybe I can. There's a way to pointer options, laser pointer. Here we go. So so in this representation, the green balls here represent oxygen, the black ones represent carbon monoxide. The inside here represents the alveolus, and this side of the slide represents the blood vessel. So in carbon monoxide poisoning, there's many more oxygen molecules than there are carbon monoxide molecules, even in high concentrations of carbon monoxide molecules. The reason they predominate is that there's a 270 times increase affinity of carbon monoxide molecules for the hemoglobin than there is oxygen. So even though there are few of them, the red blood cells take them up in preference. So the treatment of carbon monoxide poisoning, therefore, is to compete with the carbon monoxide molecules. So if you have air, you have so much partial pressure of oxygen, and the equilibrium is in this direction because of the 270 times increased affinity. But as you increase the concentrations of oxygen, you drive, as I tried to make with the thickness of this arrow, you drive the equilibrium over to this side and back to oxyhemoglobin. And this has been the standard way of looking after carbon monoxide poisoning in the world. And we do this with increasing the partial pressure of oxygen. So at atmospheric pressure, the best you can do is 760 millimeters of mercury of oxygen. But if you triple the barometric pressure, you can triple the partial pressure of the oxygen. In that case, you have very high concentrations of the oxygen, and it competes much better with the carbon monoxide, displacing it from the red blood cells. And that's a pretty straightforward, standard understanding of carbon monoxide treatment. So it's interesting that in 1962, the first hyperbaric chamber opened in Aberdeen, Scotland. And the first 12 patients that arrived there and were treated with hyperbaric oxygen had a miraculous recovery. They basically went from deeply unconscious to complete consciousness and cured. However, the next 18 patients that arrived had less and less response. And in fact, over the years in various places, the hyperbaric oxygen has a very poor record. There's a series of articles which I name here. These are review articles looking at the benefit of hyperbaric oxygen treatment of carbon monoxide poisoning. And none of these, in no country, had ever been shown to be of any benefit. Crazy. Why is that? Well, the first 12 patients that arrived at the hospital in Aberdeen, Scotland, were from the area around the hospital. The next 18, once people understood that it's such a miraculous cure, were brought from other places. And by the time they arrived, they were not treatable. So the reason hyperbaric oxygen doesn't cure carbon monoxide poisoning is because carbon monoxide poisoning is asphyxia. It's basically the internal equivalent of having a plastic bag over the head. So if one finds one's relative in bed with a plastic bag over the head, you can imagine phoning for an ambulance, putting the patient in the ambulance, driving the patient to the hospital, having the patient wait for an hour or two in the hospital till the surgeon arrives, and then cutting off the plastic bag. Well, that's what we are doing with hyperbaric oxygen. It's the time delay that is the killer here. And that's why hyperbaric oxygen will never be a practical treatment of carbon monoxide poisoning, because it just can't be provided in time to be medically effective. So some new thinking was needed. So I thought, well, what about hyperventilation? Would that increase carbon monoxide elimination? And when you think about it, it shouldn't, because when you hyperventilate, the partial pressure of oxygen is the same. The affinity of the carbon monoxide for the hemoglobin is the same. The reduction in carbon monoxide concentration in the alveoli is little, because its original concentration is little, and you could reduce it only a little bit with hyperventilation. So it actually shouldn't work. And none of my colleagues thought that it would work, and they told me that that won't work. But still, you know, I thought that it should work. And my thinking is as follows. So there's a large amount of carbon monoxide in the blood, and there's a small gradient going in. But because there's so much carbon monoxide on the hemoglobin, that there'll be an equilibration between the alveolus and the red blood cell in any event. So that if you just breathe normally, a little bit of this is lost compared to the large amount that's still in the blood with each breath. But what if you had many breaths and you had big breaths? Then surely you should get rid of a lot more carbon monoxide. But will it be significant? You know, so you get rid of a few more molecules, but is it significant? So we did the following experiment. This is experiment in a dog. Time is on the x-axis. Carboxyhemoglobin concentration, saturation is, the oxygen saturation is here carbon monoxide saturation is here, carboxyhemoglobin, and it's a log scale. So we exposed the dog and poisoned the dog carbon monoxide poisoning to about 70%. And then the dog breathes room air, and the slope of this line is the rate of elimination. Then we provide 100% oxygen, which is the current treatment, standard treatment, and the slope increases a bit, showing a faster rate of elimination. And then we did the hyperventilation, and bang, the slope increased dramatically. So to get a perspective of this, we said, well, how does that compare with hyperbaric oxygen? So we did the same experiment again, carboxyhemoglobin concentration here. We poisoned the dog. We take this is room air. We take the dog to the hyperbaric chamber, and then we start the hyperbaric oxygen. And you can see the dramatic increase in elimination. So how do these compare? Well, they compare very well. If anything, the IH, the isocapnic hyperpnea, is even steeper. And indeed, in the series of dogs, this is the half-time of elimination now on this axis. So half-time elimination on room air, on oxygen, quite a bit better. Notice the break in the axis here. But IH is much better. And the hyperbaric oxygen was the same ballpark as the IH. Okay, so hyperventilation would do, but is it practical? I mean, how can you apply that to treatment of carbon monoxide poisoning? Because when you start hyperventilation, you increase the carbon monoxide elimination for sure, but you also drop the PCO2. That decreases the brain blood flow, and people feel sick when they hyperventilate. They don't like that. And that stops them from hyperventilation. And that basically stops your treatment. Interestingly enough, if you treat people with 100% oxygen, that increases their ventilation. And I'll come back to that later in the talk, which increases the carbon monoxide elimination. But you still have an even greater drop in PCO2 and a greater decrease in blood to the brain, and people feel very sick, and you cannot use this as a treatment. So the idea was to block that branch of the effects of hyperventilation. If we can stop the PCO2 from going down, and then we would only have this main branch of carbon monoxide elimination. So how do you do that? So this is a self-inflating bag. You press, I'm sure you're familiar with this. You squeeze here, and this ventilates the patient. This is a reservoir bag. This is the oxygen coming in. So if you hyperventilate the patient with the bag, or the patient hyperventilates while breathing on the bag, this is minute ventilation. As the ventilation goes up, 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 the PCO2 goes down, 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 down. So if you wanted to stop the PCO2 from going down, what would we do now? Well, we'd get a computer. We have a flow meter, we have a carbon dioxide sensor, we have a processor, you need to plug it in, you'd have a flow controller, you'd have a CO2 tank and something controlling the flow of CO2 tank so that you replace the carbon dioxide that you're breathing off when you're hyperventilating. But that's not practical. So what about this? There's an inspiratory relief valve in the self-inflating bag. What if we just took a demand regulator? This is the same scuba demand regulator that divers use. It cost me $125 in the scuba store when I tried this. And I got a tank of 5.5% carbon dioxide. That's the PCO2 of 40, approximately at sea level. And that was it. And then I said, okay, so if I give the oxygen, I hyperventilate, and if I exceed my oxygen flow, the balance of the flow coming in, this bag will collapse, and the balance of the flow will be this 5.5% carbon dioxide, which has a PCO2 of 40, which is the same as mine. So I shouldn't get any more drop in my PCO2. So here I hyperventilate, and this is my end-tidal PCO2, and this is my inspiratory PCO2. And you can see from the pattern here that the harder I breathe, the higher the inspired concentration of CO2, such that my end-tidal and my arterial PCO2 stays constant, independent of how I breathe. And this is much more accurate than what you can do with a computer, because this is foolproof. There's no algorithm to make a mistake. It's completely mechanical. So the problem with 5.5% CO2 in a demand regulator is that you need a big tank of 5.5% CO2. Reduces the practicality of this a little bit. So we designed this where we start off with the oxygen is plentiful, and you only need 5% of what you breathe in to be carbon dioxide, so we can have a small cylinder of carbon dioxide and provide the treatment whenever you have oxygen, which you would have anyway if you were treating the patient just with oxygen. And this provides the 5.5% CO2 and balanced oxygen. So let's see if I've answered the question. Does IH increase the elimination of carbon monoxide? Yes. Is this elimination significant? Very. It's equal to what you get with hyperbaric oxygen. And another question that's a good one is, how much hyperventilation do you need to get rid of the carbon monoxide? Because if it's too much, people aren't going to do it, and people can't do it, elderly people, etc. This is an interesting experiment we did. This is humans. Here you have half time of elimination of carboxyhemoglobin, and these symbols are various humans. And this is minute ventilation here. So the interesting thing is that as minute ventilation increases, you have a right angle hyperbola as your kinetic model, which is interesting because a small increase in minute ventilation gives you a large reduction in the half time of elimination. So you don't have to do much. If you look at here, here you have minute ventilation, mils per minute per kilogram. At 200 mils per minute per kilogram, that for me would be the equivalent of me walking up 1 or 2 flights of stairs. That's how hard I would be breathing, which isn't very much, yet you get 80% of the drop in half time of carboxyhemoglobin that you would get in a hyperbaric chamber. You're already at 80% with a mild increase in ventilation. So how much ventilation is needed? Not much. 15 liters a minute, and you're 80% of the way there. So how can we get an awake patient to hyperventilate? The patient comes in, they may have tried to commit suicide, or they may be drunk or semi-conscious, and how do you get them to hyperventilate? So this comes from Becker et al., and it shows you this is inspired oxygen percentages. This is minute ventilation here. And at 75% oxygen, you've already more than doubled, 200% increase in minute ventilation. The oxygen itself is a respiratory stimulant. So 100% oxygen, you get hyperventilation and carbon monoxide elimination. If you're allowed to increase your minute ventilation, the carbon monoxide elimination goes up a lot. And you've blocked all the side effects of your hyperventilation. And you do this with this device here. And you have no ill feeling. No matter how hard you breathe, you feel the same as if you're breathing right now there. So all this is described in great detail in this paper from Experimental Physiology. You can find it if you put in my name. If you go into PubMed, you put in my name, Fisher J.A., and then just put coming full circle. And this paper comes up, and everything that I've just shown is described in there. And this is a study that we found. We didn't know that this was being done. This was a study that was published in a Chinese journal that we just basically tripped on. And this was an interesting study where between October 2012 and January 2014, they treated 320 patients who came in with carbon monoxide poisoning with hyperbaric oxygen. And then from February 2014 to May 2015, they treated another approximately 320 patients, but they treated them with the ClearMate first. In other words, they got the treatment well before waiting to get into the hyperbaric chamber. And here are the outcomes. So the time to regain consciousness in the just hyperbaric chamber was 30 hours. With ClearMate, it fell to 12 hours. A delayed neurological sequelae, which is the main neurological injury that one gets that is long-lasting, was about 20%, which is in the low end of what is found in other studies, between 20 and 45%. But if you use the ClearMate first and treated them early, it was down to 1%. And the outcome score, they followed them up after 2 years, and they scored them to see if they were good or excellent or bad and poor. So 71% were good to excellent. And the ones with the ClearMate, 99% were good to excellent. So if it's so good, why wasn't it done before? This technology is clearly has been available since the 1920s and probably earlier, could have been done mechanically. Why wasn't it done before? Well, it seemed that nobody thought of it. So this is the system, a self-inflating bag with a device that provides you with 5% CO2 balanced oxygen and is very sparely uses the carbon dioxide. And early IH markedly decreases the morbidity, as the study from China shows. And there are no foreseeable side effects. You don't lose anything. In the worst case scenario, the patient gets 100% oxygen anyway. So it always seems impossible until it's done. But the mistake was that it wasn't impossible. It was just inconceivable.